Hello students, now we will discuss systemic vasculitis. The vasculitides are defined by the presence of inflammatory leukocytes in vessel walls with reactive damage to mural structures. Both loss of vessel integrity leading to bleeding and compromise of this lumen may result in downstream tissue ischemia and necrosis. The International Chapel Hill Consensus Conference has developed one of the most widely used nomenclature systems which specifies the names and definitions for most forms of vasculitis. Classification of the non-infectious vasculitis is primarily based upon the predominant size of the vessel involved, although there may be some overlap in the size of arteries involved with all these diseases. Thus, large vessel vasculitis, as its name suggests, mostly affects large arteries. The same principle is true for the medium and small vessel vasculitis, in which medium vessel vasculitis predominantly affects medium arteries and small vessel vasculitis predominantly affects small arteries and capillaries. The clinical features of systemic vasculitis include systemic inflammatory or constitutional symptoms like fever, sweating, loss of appetite, weight loss. Classic dermatologic presentation is palpable purpura. Skin lesions may also include urticaria, livedo reticularis, nodules, ulcers, and vesicles. The nervous system affected like mononeuritis multiplex, sensory neuropathy, cranial nerve abnormalities, central nervous system mass lesions, external ophthalmoplegia, sensorineural hearing loss. The musculoskeletal system, arthralgia or arthritis, muscle pain or claudication. The respiratory system, sinusitis, epistaxis, pulmonary infiltrates. Gastrointestinal system, abdominal pain, bloody stool, renal system, glomerulonephritis, or hypertension. There are some diagnostic clues for systemic vasculitis. Palpable purpura is specific for small vessel leukocytoclastic vasculitis. Hepatitis B virus associated with polyarteritis nodosa, hepatitis C virus with cryoglobulinemia. Wrist or foot drop due to mononeuritis multiplex associated with polyarteritis nodosa or eosinophilic granulomatosis with polyangiitis. Oral and genital ulcers. You must think about Behcet syndrome. Upper lower airway disease and glomerulonephritis specific for granulomatosis with polyangiitis, lower airway disease and glomerulonephritis, microscopic polyangiitis or Goodpasture's disease, asthma and eosinophilia specific for eosinophilic granulomatosis with polyangiitis, and young female with extremity claudication and hypertension specific for Takayasu arteritis. Laboratory tests that are helpful in the diagnosis of vasculitis. Tests suggesting immune complex formation and or deposition, rheumatoid factor and cryoglobulins, antinuclear antibodies, low C3 or C4 levels. Test suggesting necrotizing vasculitis without immune complex deposition, anti-neutrophil cytoplasmic antibodies. And test suggesting systemic inflammation, ESR and CRP. And the summary, when a patient has a complex multi-system inflammatory picture, think vasculitis. If a vasculitis disorder is considered, search for its cause. Hepatitis B virus for polyarteritis nodosa, hepatitis C virus for cryoglobulinemia. Rapid diagnosis and treatment is organ or life-saving. Consider other vasculitic syndromes when the autoantibodies are negative. Now let's discuss systemic vasculitis separately. Giant cell arteritis, also known as Horton disease, cranial arteritis, and temporal arteritis, is the most common of the systemic vasculitides. It virtually never occurs in individuals younger than 50 years of age and peaks in incidence is the 7th decade. Polymyalgia rheumatica is an inflammatory rheumatic condition characterized clinically by aching and morning stiffness about the shoulders, hip girdle, and neck. Polymyalgia rheumatica occurs in about 50% of patients with giant cell arteritis, and giant cell arteritis occurs in 10% of patients with polymyalgia rheumatica. Clinical manifestations of giant cell arteritis: symptoms due to cranial vessel involvement, new onset headache, jaw claudication or pain on chewing, scalp tenderness, abnormalities of the temporal artery, pain, nodules, absence of pulse, loss of vision. Symptoms due to involvement of great vessels, aorta or branches, claudication of extremities, generally upper. Symptoms due to systemic inflammation or constitutional symptoms, fever, night sweating, weight loss, and 4th system of polymyalgia rheumatica. In the first picture, we see abnormal temporal artery. In second picture, scalp infarction due to temporal artery occlusion. Tongue infarction. ACR classification criteria for giant cell arteritis. First, age more than 50 years. Second, new onset headache. Third, temporal artery abnormalities, for example, irregularities or nodulity of the arterial wall. Fourth, ESR greater than 50 mm per hour. And fifth, histologic evidence of arteritis on temporal artery biopsy, no mononuclear cell infiltration or granulomatosis inflammation. Presence of 4 of these 5 criteria enough for the diagnosis of giant cell arteritis. Takayasu arteritis or aortic arch syndrome or pulseless disease is a chronic, progressive, inflammatory, occlusive disease of the aorta and its branches. The inflammatory process results in stenosis, occlusion, dilation or aneurysm formation in the arterial wall. Women are affected in 80 to 90% of cases, with an age of onset that is usually between 10 and 40 years. It has a worldwide distribution, but the greatest prevalence in Asia. Angiographic classification of the Takayasu arteritis. Type 1. Involvement only aortic branches. Type 2A. Involvement of the ascending aorta, aortic arch and branches. Type 2B, involvement of the ascending aorta, aortic arc, descending aorta and branches. Type 3, thoracic and abdominal aorta and its branches. Type 4, abdominal aorta and its branches. And 5. Fifth type is a total involvement. In the first picture, we see stenosis of the proximal part of the brachiocephalic trunk and left subclavian artery. In the second picture, occlusion of the right iliac artery. And in the third picture, stenosis of the left and occlusion of the right iliac arteries. Clinical manifestations. First is the constitutional symptoms: headache, malaise, arthralgia, fever, weight loss. Cardiac and vascular features: bruit, with the most common location being the carotid artery. Blood pressure difference of extremities, claudication, carotidynia, hypertension, aortic regurgitation, Raynaud syndrome, pericarditis, myocardial infarction. Neurologic features: visual disturbance, stroke, transient ischemic attack, seizures. In some cases, dermatologic manifestations: erythema nodosum, ulcerative nodular lesions, pyoderma gangrenosum. Classification criteria for Takayasu arthritis is age less than 40 years onset, claudication of extremities, decreased pulsation in one or both brachial arteries, unequal arm blood pressure more than 10 mm hydrargyrum, subclavian or aortic bruit, angiographic evidence of narrowing or occlusion of the aorta or its primary branches, or large limb arteritis. The presence of 3 or more of the 6 criteria was sensitive, 91% and specific, 19%, for the diagnosis of Takayasu arteritis. Treatment of the large vessel arteritis is generally the same. For giant cell arteritis, we start glucocorticoids 40 to 60 mg orally or 250 to 1000 mg intravenous injection in presence of visual problems. Then taper to 15 to 20 mg within 2-3 months. If target achieved, continue tapering. If treatment failed, start tocilizumab or methotrexate. For Takayasu arthritis, in the first phase we add synthetic DMARDs like methotrexate. In the second phase we add tocilizumab or TNF-alpha blockers. Polyarteritis nodosa is a systemic necrotizing vasculitis that typically affects medium-sized muscular arteries, with occasional involvement in small muscular arteries. The annual incidence was estimated to be 2 to 4 per million in hepatitis B endemic regions, from 70 to 80 per million. Patients typically present with systemic symptoms: the kidneys, skin, joints, muscles, nerves, and gastrointestinal tract are commonly involved, usually in same combination and sometimes all at once by the time of diagnosis. Livedo reticularis, first picture, second lung ulcers, and third papillopetechial rash. For the diagnosis, we use these criteria. Otherwise, unexplained weight loss greater than 4 kg. Livedo reticularis, muscular, testicular pain or tenderness, myalgias, non-proximal areas, muscle weakness or leg muscles tenderness, mononeuropathy, mononeuritis multiplex or polyneuropathy. New onset diastolic blood pressure greater than 90 mm hydrargyrium. Elevated of hepatitis B virus infection. Characteristic arteriographic abnormalities. A biopsy of small or medium-sized artery containing polymorph nuclear cells. The presence of 3 or more criteria was sensitive 82% and specific 84% for the diagnosis of polyarteritis nodosa. For the treatment used glucocorticoids and immunosuppressants, antiviral drugs for hepatitis B. Kawasaki disease, previously called mucocutaneous lymph node syndrome, is one of the most common vasculitis in childhood, particularly in East Asia. The incidence among children younger than 5 years of age was approximately 112 per 100,000 people. Peak age between 2 to 5 years, and 85% of patients under 5 years. Diagnosis is based upon evidence of systemic inflammation, fever, in association with signs of mucocutaneous inflammation. The characteristic bilateral non-exudative conjunctivitis, erythema of the lips and oral mucus, rash, extremity changes, cervical lymphadenopathy, which typically develop after a brief non-specific prodrome of respiratory or gastrointestinal symptoms. Other symptoms include arteritis, myocarditis, coronary artery inflammation. The diagnosis of Kawasaki disease requires the presence of fever lasting at least 5 days without any other explanation combined with at least 4 of the 5 following criteria. First, bilateral conjunctival injection. Second, oral mucous membrane changes, including injected or fissured lips, infected pharynx, or strawberry tone. Third, peripheral extremity changes, including erythema of palms and soles, edema of hands or feet, and periungual desquamation. Fourth, polymorph rash, and fifth, cervical lymphadenopathy. For the management, used intravenous immunoglobulin and aspirin. Anti-neutrophil cytoplasmic antibodies associated vasculitis (AAV) include granulomatosis with polyangiitis, microscopic polyangiitis, and eosinophilic granulomatosis with polyangiitis. There are two types of ANCA anti-neutrophil cytoplasmic antibodies: C-ANCA or anti-proteinase 3 and P-ANCA or anti-myeloperoxidase antibodies. Granulomatosis with polyangiitis is a complex immune-mediated disorder in which tissue injury results from the interplay of an initiating inflammatory event and a highly specific immune response. The prevalence is 3 per million people. Age of onset 4 years. Clinical features include constitutional symptoms like fever, malaise, anorexia, weight loss. Other symptoms: nasal crusting, sinusitis, otitis media, earache, otorrhea, rhinorrhea, nasal discharge bloody or purulent, oral or nasal ulcer, polychondritis, saddle nose deformity, and retroorbital pseudotumor. Saddle nose deformity, polychondritis or inflammation of the ear cartilage, mouth ulcers with perforation, strawberry hypertrophic gingivitis, retroorbital pseudotumor with proptosis, unilateral or bilateral, purpuric rash, vesicles, and ulcers. Tracheal stenosis causing hoarseness. Pulmonary infiltrates with cavitation. Renal involvement generally type rapidly progressive glomerulonephritis. For the diagnosis of granulomatosis with polyangiitis, three of the following 6 features should be present: abnormal urinalysis, granulomatous inflammation on biopsy, nasal sinus inflammation, subglottic, tracheal or endobronchial stenosis, abnormal chest X-ray or CT, and proteinase 3 or C-ANCA staining. Microscopic polyangiitis is the type of ANCA-associated vasculitis and is more prevalent than granulomatosis with polyangiitis in Asian population. Cutaneous petechial rash, Other symptoms are constitutional, fever, weight loss, and pulmonary and renal symptoms. On biopsy, we have necrotizing palsy immune inflammation of arterioles, capillaries, and venules without granulomas and eosinophilic infiltrates. Eosinophilic granulomatosis with polyangiitis or Church-Strauss syndrome or allergic granulomatosis and angiitis is a multi-system disorder characterized by allergic rhinitis, asthma, and prominent peripheral blood eosinophilia. The incidence is 1 to 3 per million people, age of onset 4 years. The clinical features of eosinophilic granulomatosis with polyangiitis typically develop in several sequential phases. Prodromal phase. The prodromal phase occurs among individuals in the second and third decades of life and is characterized by atopic disease, allergic rhinitis, and asthma. Eosinophilic phase. Features of the eosinophilic phase include peripheral blood eosinophilia and eosinophilic infiltration of multiple organs, especially the lung and gastrointestinal tract. Vasculitic phase. In this phase, we have life-threatening systemic vasculitis of the medium and small vessels and is often associated with vascular and extravascular granulomas. For the diagnosis of eosinophilic granulomatosis with polyangiitis needed 4 of the 6 criteria and biopsy evidence of vasculitis: asthma, eosinophilia, mononeuropathy or polyneuropathy, migratory or transient pulmonary opacities, paranasal sinus abnormalities, and on biopsy accumulation of eosinophils in extravascular areas. For remission induction of new onset organ-threatening or life-threatening ANCA-associated vasculitis, recommended combination of glucocorticoids and either cyclophosphamide or rituximab. For remission induction of non-organ threatening ANCA-associated vasculitis, recommended combination of glucocorticoids and either methotrexate or mycophenolate mofetil. Also recommended plasma exchange. Immunoglobulin A vasculitis. IgA vasculitis, formerly called Henoch-Schönlein purpura, is the most common form of systemic vasculitis in children. 90% of cases occur in the pediatric age group. Clinical manifestations are constitutional symptoms, fever, anorexia, headache, arthralgia, abdominal pain, gastrointestinal bleeding, immunoglobulin A-associated nephropathy, pulmonary hemorrhages. Classic manifestation is palpable purpura. The majority of patients with immunoglobulin A vasculitis recover spontaneously. For other cases, used NSAIDs, glucocorticoids, in some cases immunosuppressants, intravenous immunoglobulin, or plasma exchange. Cryoglobulins are immunoglobulins that precipitate in vitro at temperature below 37 degrees Celsius and redissolve after rewarming. And 50% of cases have been associated with hepatitis C. There are three types of cryoglobulins. Type 1. Isolated monoclonal immunoglobulins, generally associated with hematological neoplasm. Type 2. Mixture of monoclonal immunoglobulin M and polyclonal immunoglobulin G. And type 3. Mixture of polyclonal immunoglobulin M and G. A and B pictures is palpable purpura. C and D are livedo reticularis. In E we see leg ulcers, and F leg scars after ulcers. Treatment depends on clinical features included. First, treatment of underlying conditions. Plus, used glucocorticoids, immunosuppressants, plasma exchange, and rituximab. And the last type of vasculitis is Behcet syndrome, also known as Behcet disease, which characterized by recurrent oral aphthia and any of several systemic manifestations including genital aphthia, ocular disease, skin lesions, gastrointestinal involvement, neurologic disease, vascular disease, or arteritis. Behcet syndrome is more common and often more severe along the ancient Silk Road, which extends from Eastern Asia to the Mediterranean. It typically affects young adults 20 to 40 years of age. What we see first is aphthous ulcers or aphthostomatitis, skin pustules, erythema nodosum, painful red nodules, generally in lower extremity, uveitis, and hypopionuritis. Classification criteria for Behcet syndrome: recurrent oral aphthia plus two of the following clinical features. Recurrent genital aphthia, aphthous ulceration or scarring. Eye lesions including anterior or posterior uveitis, cells in vitreous on slit lamp examination, or retinal vasculitis observed by the ophthalmologist. Skin lesions including erythema nodosum, pseudovasculitis, papulopustular lesions, or acneiform nodules consisting with Behcet syndrome. And positive pathology test. Pathology is defined by a papule 2 mm or more in size, developing 24 to 48 hours after oblique insertion of a 20 gauge needle 5 mm into the skin, generally performed on the forearm. For mucocutaneous involvement, used topical steroids and colchicine. For eye or vascular involvement, immunosuppressants or TNF-alpha blockers. For severe gastrointestinal involvement, glucocorticoids and 5-aminosalicylic acid or azathioprine. For central nervous involvement, immunosuppressants or TNF-alpha blockers. For joint involvement, intra-articular glucocorticoids or colchicine. So thank you for your attention.